Good morning, everyone. And I'm really thankful for giving me this opportunity for presenting our work on management of acetabular fractures. But before I start this topic, I would like to give a brief introduction about what acetabular fractures are. Like many people think pelvic fractures and acetabular fractures are both as a single entity, but they are not. So I will start with a brief overview about the acetabular fractures. And of course, I will have to go into a bit detail about the classification as well, because if I do not tell about the classification, anything further will not be it will be incomprehensible. So I would start with my presentation. So things that I'm going to discuss is basically first, what are the acetabular fractures? Secondly, a brief history about the acetabular fractures, the classification part, our census, like the number of cases that we have operated, the management of acetabular fractures, the basic principles and the surgical approaches. And if the fractures do not do well or the patient presents late, as is often scenario in our India, so those cases will also be discussed. And finally, I will be showing the cases that we have done at Apex Trauma Center. So starting with the anatomy, what is pelvis? Pelvis is nothing but it's a ring structure composed of three bones, the two innominate bones and sacrum. The innominate bones or the hip bone is basically consisting of three parts: the ilium, ischium, and the pubis. We all know that. And the hip joint is formed by the femoral head, which is the ball, and the acetabulum, which forms the socket. So acetabulum is the socket part of the hip joint, and pelvis is the ring. So if the ring is disrupted at any point, so we label that as pelvic fracture. So, and if there is a fracture of the socket part of the hip joint, that is the acetabular fracture. However, there may be certain scenarios where the fracture is such that it disrupts the ring structure of the pelvis, and simultaneously it also hampers disrupts the articular surface of the socket. So those fractures are known as combined pelvic acetabular injury. Now, it's not like it's just the socket. The socket is basically supported by two pillars. So this was a concept which was given in around 1964 by Judith and Luternal. So they said that the acetabular cavity that we often think of is nothing but it's sandwiched between two pillars. There is an anterior pillar which comes from the way above from the ilium to the pubis, or it is also known as the iliopubic column, because it comes from the ilium to the pubis. And there is a small posterior column, but it's more robust and more structurally more important, and that is the posterior column, which comprises mainly of the ischium. So you can see that there are four things over here. There are two columns, anterior column and the posterior column. And, to form the hip joint, the part of the acetabulum, covers up the head. So the protruding parts of the acetabulum, which is, protrudes a bit laterally, those are the walls. So there are anterior column, posterior column, and two walls on either side, which covers up the femoral head. So there may be fracture of any four of them. So based on these, the classification will come into picture ahead. Now coming to the brief history of this acetabulum, the first description was given in around 8th century BC in the literature Horner's Iliad, where they have described the hip bone turns into pelvis. That means goes inside the pelvis. It was Hippocrates who first described about the hip dislocations, and until 19th century, the acetabular fractures were considered to be hip dislocations only. There was no demarcation was made between the dislocations and the acetabular fractures. The first actual literature on acetabular fracture was given by Ashley Cooper in 1918, and this was described on an autopsy specimen. There were 49 cases of central fracture dislocation that was described by Schroeder. And although at that time, the First World War and then Second World War were going on, and the results of these patients were mainly invariably poor, because all those patients were managed conservatively. And till first half of the 20th century, the results were conservative, and so the results were poor. However, there was a surgeon known as by the name of Émile Luternal, who was actually studying in France while doing his graduation. And that institute had to be shifted to Scotland during the Second World War. And he had to cross the whole Atlantic to reach Scotland, and he studied over there. And once the World War was finished, he came back to France, but he had no letters of recommendation at that time. So eventually he went from one surgeon to the other, and finally he landed up with Robert Judet, who just told him that you go and do some work on acetabulum, because acetabulum was considered to be a very low level of specialty at that point of time. It was, in fact, not considered to be a subspecialty of orthopedics. So Luternal had no option but to start doing some work on acetabulum. And as we say that when life throws you lemons, make it lemonade. So that is what he did. He studied all those cases and he came up with his own mechanism, classification, and treatment of acetabular fractures. And he published his first paper with his teacher, Robert Judet and Jean Judet, in 1964 in JBJS. And as you can see that this paper, this was the first landmark paper given by these three surgeons. So they also published a book, Fractures of the Acetabulum, in French, which was later on translated to English in 1991. So this book is still considered to be the Bible of acetabular surgery. And gradually things started spreading far and wide. And in 1988, there was a surgeon from by the name of Joel Mata from US, who popularized this in North America. And later on, this same surgeon, Joel Mata, published the largest case series of 810 patients from USA that came in 2012. So you can see that this specialty is not that very old. This subspecialty has evolved in the last, I would say, 2 to 3 decades. And for the first time around 50, 60 years back, this was described in a comprehensive manner. Now, as the work of Judet Letournel, I mean, I told you that there are 4 things, the 2 columns and the 2 pillars. But it's not like you just make any combination out of them and come up with a classification. They actually studied 647 fractures, and then they found that there was a common pattern amongst these fractures. And based on those fractures that they saw, they also tried to decipher the mechanism of injury, the vector of injury force, and also tried to correlate that with the operative findings. And by this time, remember that X-ray came into picture around the last part of the 19th century. So X-ray had come up by this time. So based on all these, they came up with this classification. And we are still following this classification. It's very rare that the first classification that is propounded is still being followed till date. So I will just briefly touch upon the classification. So they saw that in most of these fractures, there were either a single fracture line or there were more than one fracture line. So cases where there was a single fracture line were labeled as elementary types, as you can see in the first upper part of this classification picture. And all those fractures where there were 2 or more fracture lines were labeled as associated types. So I will be just showing you a video of each of these fractures, the 3D CT scan video of each of these fractures, so that you are able to understand what this fracture looks like. So if you can see that the green part on the right is the posterior column and the blue part is the anterior column. So as you can see that the posterior rim of the acetabulum is only lost. The whole rest of the ilium bone, the bone is still intact. So this is the posterior wall. Then comes the posterior column. As you can see, the posterior column is broken and not just the wall. The anterior wall fractures are very rare. So we could not get any CT scan of this, the actual CT scan of just the anterior wall fracture. So in this figure, the blue that has been shown is the anterior wall part of the fracture. Just the rim part is the walls, and the column is coming away from the ilium to the pubis. So just the wall is. So this is the anterior column because, as you can see, it comes from the ilium to the pubis. Then there is transverse fracture. In this transverse fracture, the fracture line goes from across both the columns, and it's more like a horizontal kind of thing. Of course, it can have other ramifications, but then most likely it's a horizontal fracture. Then there is now coming to the associated types where there are more than one fracture line. So there can be posterior column as well as posterior wall fracture. There can be transverse with posterior wall fracture. There can be T-type fracture where both the columns are separate and there is a horizontal component. Then there is anterior column posterior hemi-transverse fracture where the major injury is on the anterior component, but there is a fracture line going through the posterior column as well. And there is associated both column fracture. Associated both column fractures will not have any in part of the acetabulum which is still in continuity with the rest of the pelvis. So managing these fractures are a bit difficult, because you do not have any stable platform upon which you can build your, create your own building. Now, coming to after classification, I would like to tell about our census. Till now, we have managed 113 such fractures, out of which most commonly we have encountered is the posterior wall fracture, which are relatively easy to manage. And second most common variety is the associated both column, which is the most severe. So, this is an entire spectrum. So most of our patients, although they are, either they are having very low level injury or they are having the most severe kind of injury. And of course, there is a spectrum. You can see that we have operated till now 113 such cases. I mean, these census excludes the pelvic fractures per se. These are only the acetabular fractures. Now coming to the management of acetabular fractures. So basic principles, I would say these fractures often come up with, they are polytrauma patients. They have some other injuries as well, like the head injury, chest injury, abdominal injuries. So you have to stabilize first these patients by the help of by ATLS protocol. And if the patient is not amenable for surgery right at the start, then we have to do some kind of primary management like giving traction and reduction of dislocation. These are basically, dislocation is an emergency which has to be managed either in the ER itself, or patient can be taken in OT, and under sedation we can reduce the dislocations. There are certain fractures which are either non-displaced, or the patient profile is such that he or she cannot be operated. So those are the few cases which have to be managed conservatively. Otherwise, as a rule, most of these fractures has to be managed operatively. Now, the goals of surgical treatment is like any other articular fracture. You have to have complete articular reduction. See, there are two kinds of reduction. One is anatomical reduction, one is provisional reduction kind of thing. Anatomical reduction means bilkul jaise chool se chool baithana hai. Or other is like you can have some bit of incongruency. But in these articular fractures where there is joint is involved, you need to have complete reduction. So these fractures have to be properly seen, visualized, and then only you can fix this fracture. Because even if there is a step, this can eventually, after 1 or 2 years down the line, turn up into some kind of arthritis, and the patient may require some kind of joint replacement. So these fractures has, anatomical reduction is required, a good fixation so that we can mobilize the patient as early as possible. But before going for surgery, we have to plan the case. If you cannot plan properly, you are doomed to fail, as we say in surgery. So we have to plan the patients properly. We need different kind of views, like the proper AP view we are all familiar with, but we also have to take juded views, like the patient is turned inward or outward 45 degrees, and then that helps us to better localize the columns of both the columns of the acetabulum as well as the walls. Nowadays, because of the advent of CT scan, the things have become much easier. People often just first of all look at the 3D CT picture, but mind you, there is 2D CT as well, and at times there may be marginal impaction, like the cartilage is shattered inside, and from the outside it may look quite well, but in the inside there is shattering of the cartilage, and the cartilage may have been pressed inside the bone, because the bone is quite cancellous around the joint area. So that can only be evident on the 2D CT scan. So I would ask all our residents to first look at the 2D CT scans and then look at the 3D picture. And then the classification of fracture. Of course, we have to classify these fractures so that we are able to formulate a plan and go according with that. And the choice of surgical approach, the basic rule of thumb is that wherever the fracture is more displaced, from that side you have to approach the fracture. On the undisplaced side, you can go for percutaneous fixations, but on the side where the fracture displacement is huge, then you have to address from that side. And there is also an upcoming concept of replacement in such scenario. Like if the fracture is such that even whatever you do, it may not be, get 100% reduction. So it's better to replace the joint in the first instance itself, rather than waiting for the joint to go into osteoarthritis after fixation and then doing a joint replacement. But that's an upcoming concept. Still, we follow fix first. If the patient goes into osteoarthritis, we can look after the joint and do a joint replacement later on. And the rehabilitation part, again, the role of the rehabilitation team cannot be overemphasized in this case, because it takes around at least 6 weeks before we can actually make the patient stand on his own feet, because that's the weight bearing part. If you allow the patient to weight bear too early, then the fracture reduction and everything can be lost. Now, as I said, that whichever part there is a fracture, you have to address that from that direction. Acetabulum goes both anteriorly and posteriorly. So if there is a fracture, if the fracture is more displaced anteriorly, or there is a fracture of the anterior part only, then you can go from one of the anterior approaches. Now, the ilium to the pubis is a very big structure. So there are different approaches based on what part of the, the anterior part of the hip bone that you want to actually access. So the first was the ilioinguinal approach that was described by Juliet and Luternal. Then recently, iliofemoral approach has come into picture, which is just one of the parts of the ilioinguinal approach. We just access the lateral aspect of the ilium bone. And there is a modified stoppage approach. This incision that you are seeing is often given by the gynae people, phalansteal incision. But as orthopedic surgeons, we are quite scared about going into the abdomen. But nowadays, people are doing more and more of acetabular, and now we are going by this approach, and modified stoppage along with iliofemoral has become the workhorse for us for the anterior fixation. Then there are posterior approaches. There are, the Cocker-Langenbach gave the first approach that could assess the posterior column and the posterior wall. And after that, we found that the superior part of the posterior column could not be accessed that well. And so the people like Gibson came up with their own approach. And thereafter they saw that even then we could not access that properly. So they started doing they started osteotomizing the trochanter and took the whole of the trochanter with the abductors attached and the vastus lateralis anteriorly, and that enhanced the further exposure. So things are evolving over time. And then finally, the GAN safe surgical dislocation. There are many circumstances where it's not just the the socket which is fractured, but the ball itself is also fractured. So in those cases, you need to access the head as well. So those are so in those circumstances, you need to take out the head anteriorly and see if whether the head has been fractured or not. And in those cases, we go for GAN safe surgical dislocation. Now coming to some of our cases, I think the theoretical part is over. So I will be coming to our cases that we have done. So this starting with one of the simple cases like the posterior wall fracture. This is a common scenario, like the patient is sitting in a car and the car hits some vehicle in front, or a pole or something like that, and the knee hits the dashboard of the car and the femoral head pushes the posterior part of the acetabulum, and then we end up with something like this. There is a fracture of the posterior wall of the acetabulum. The head, you can see, has come out, fracturing the posterior wall as well. So in the 3D CT, you can see that this is the posterior wall fragment. And many times this is very innocuous. If you just look at the X-ray, it's not quite that evident because the posterior wall fragment overlaps the rest of the the pelvic bone. So at times, in fact, I have also encountered one of the cases where the patient was complaining about the pain in the right hip joint, and we thought that there is nothing, and the patient had no money, so we did not go for CT scan. And after 1 or 2 months, we found that the hip was becoming arthritic, and we found that there was a posterior wall fracture which we had missed. So these fractures are many times quite innocuous. Until unless the patient comes with a dislocation, we can miss these fractures. So CT scan is mandatory in such scenarios. And as you can see that we went ahead with the Cocker-Langenbach approach in this case. Here you see that there is a fracture, and in this you can see that the fracture is well reduced. There is a plate applied over here, and now the hip is congruous, and the patient is back to his own feet at 3 months follow-up. Here you can see that the fracture is reduced. There is a plate applied over it, and the hip joint is congruous. Now the second case. There is not just when like the patient is going on a bike, the hip is abducted, and then his knee hits something obstacle outside. Then it does not just takes off the rim of the acetabulum; it also fractures the wall, because if there is more abduction, it hits more towards the inside. So in those scenarios, there is fracture of the wall as well as the column. So this was one of the cases which was referred to me from one of my juniors. And as these patients are most often, I said, the polytrauma victims, you can see that the patient had a femoral shaft fracture on the opposite side and a humeral shaft fracture as well. And this patient was, again, we had to fix all these fractures, and we tried to reduce this fracture in the emergency. We reduced it, we were successful. Just look at the X-ray. It seems like it's a normal, there's just a flake of bone over there. But once we got a CT scan, we found that the femoral head was out, and there was a fracture of the posterior wall as well as the column. So CT, that is why I said that CT scan is a must in these kind of scenarios. We went ahead with fixation of all these fractures. And as you can see that at six weeks, when the patient came for follow-up, I have started mobilization of the patient. You need a good fixation before you can actually mobilize the patient. Now, anterior column fracture. This was a simple case where the patient had a dashboard injury, and as you can see that there is a fracture of the anterior column over here. And I will not go into too much detail about this CT scans. And you can see that just by the iliofemoral approach, a straightforward iliofemoral approach, we could access this fracture. We fixed the fracture, we compressed this, and now the hip joint is quite congruous, as you can see. These are the Judet views that we often take during the surgery, while we are doing the surgery. We applied a plate first, and then I found that this was not that stable or that robust fixation, so I applied a second plate as well. Now, a third case. Like initially, I said that still now we are following the Judet-Lutyens classification, but most of these fractures are coming into one of those categories. But there are a few fractures which may not come into that classification. So this was one of the fracture types which was kind of unclassifiable, I would say, based on the Judet-Lutyens classification. So this was again a similar kind of case, but there was a transverse fracture. As you can see, there was a transverse fracture along with a fracture of the anterior column. Although the fracture was grotesque, but you can see that just by the standard iliofemoral approach, we could access the fracture and we could fix both the ilium as well as the supraacetabular area. Of course, in scenarios like this, where you need a big exposure just by this one single approach, we need to do an AS, anterior superior iliac spine osteotomy to enhance the further exposure, which has to be fixed later on, as you can see in this. There is a nerve, lateral femoral cutaneous nerve, which goes right around the ASIS, which has to be isolated. If you do not isolate it properly, patient may have numbness and tingling of the anterolateral aspect of the thigh in the postoperative period. Now coming up with some severe injuries. Like this was a patient who was having associated transverse with posterior wall fracture. He has fracture of the distal radius as well. And this patient had some kind of head injury also. This patient was, first of all, we fixed this. We went ahead with the stoppage approach. At this point, I would like to tell you something about the corona mortis. Why people were so scared about going ahead with the acetabular surgery. There is an entity described in the anatomy literature known as corona mortis. Corona mortis is nothing but it's a anastomotic communication between the external iliac system and the internal iliac. The obturator vessels are basically coming from the internal iliac. So there is a communication between obturator vessels and the external iliac, and those vessels are known as corona mortis. It was thought to be as crown of death. If somebody would have just cut these vessels during the surgery, it was thought that the patient would die, and that prevented many of the potentially those who could become acetabular surgeons going into this field. So this was a very, this corona mortis, as you can see in this diagram. So you have to take down the corona mortis before you expose this part of the bone. And many times the fracture itself has already done the work for you. I mean, there is not that much to be scared of. This is, I talked to a general surgeon before doing my first case, and he simply said me that corona mortis is a myth. You should not be scared about that. I am here if something happens. And I went ahead with my first surgery of acetabulum around 8 or 9 years back. So as you can see that in this case, again, we have to decipher the corona mortis properly. We ligated it, and then we isolated the fracture and fixed this. So firstly, we fixed from the anterior aspect, and then later on, we fixed from the posterior aspect as well. As you can see that these are the intra-articular loose bodies that we have removed. Even after fixation, there may be some fragments of bone which may lie within the joint, and it's our duty to remove those fragments, because if we leave them as such, then that may, enhance the chances of osteoarthritis in the future. And despite good fixation and reduction, you may land up with osteoarthritis in these patients. However, this patient was doing quite well. But again, as you know, कुछ लोगों की किस्मत ही जैसे खराब होती है. So this patient was having some kind of itching around the catheter, and he pulled the catheter all by himself. And immediately the patient's condition deteriorated, and he became, feverish, and patient had to immediately transfer to ICU. And I am really thankful to our anesthesia people for helping us out in this case, and in many cases like these. They have always been standing behind us in all these kind of fractures. And this patient had to be managed by suprapubic cystostomy. We sent for blood culture and urine culture, and in both of them, there was Klebsiella organism. So it was evident that while pulling the catheter, Klebsiella had gone inside the blood, and that had caused bacteremia, and which eventually led the patient to go into septicemia. However, because of the multidisciplinary team effort, this patient was revived, and today he is back to his own feet, and he is having a big, shopping store in Allahabad, Prayagraj, and he is doing quite fine. Then coming to the next severe type, this is T-type fracture, where I said that there is transverse component, both the anterior and the posterior column are separated from each other. So this was a young girl around 23 years old, and we had to, again, because the two pieces were separate, we had to go both from the anterior side as well as the posterior side. And firstly, we went ahead with the anterior side, we fixed the fracture, and later on, we went from the posterior side. And we found a variation of the sciatic nerve. Like sciatic nerve, we have read that there are 5% cases where the sciatic nerve is like there are two branches which unite to form the sciatic nerve. We have all read that. But that two divisions may come as far down as the piriformis muscle in certain scenarios. So you have to actually see what's the anatomy of the sciatic nerve before you actually expose the bone and apply a plate over there. So since this was a rare case, we came up, we published this as a case report, and because as you know, in medical science, it's said that if your eyes see what your mind knows. So I thought that people should be knowing about this, and then we published a case report. And in this patient, as you can see, the follow-up at 2 years, the patient is doing quite well. Now, these were the cases which were managed, like the patient came immediately after the fracture, or say around a week or two after the fracture. But there are many cases like in India, the patient, they are reluctant for surgery. They are not very sure whether the doctor what is saying is right or not. So they often, buy some time, and at times the patient may end up coming to you at say 6 weeks or 12 weeks or even at 6 months. So in fact, because of COVID, we could not manage a few patients that I will show. Those patients who came at around say 6 months after the COVID was over. So we had to manage those patients as well. So even if those patients which are neglected acetabular fractures, they are one entity. And there is a different entity like the patients who have been, you have treated them to the best of your efforts, but they did not do well. They landed up with some kind of avascular necrosis or the osteoarthritis of the hip. Now, if landing up in AVN has got more to do with the initial insult itself. Like when there is a fracture and the hip dislocates posteriorly, the blood supply of the femoral head is lost. So because of the loss of the blood, nobody can predict at that point of time whether that hip is going into AVN or not. Of course, the MRI is most sensitive, but just at the time of injury, it's very difficult to predict because the signal changes in the femoral head is not that evident at that time. But we have to follow up the patients, and some of those our patients have eventually gone into avascular necrosis, and we had to again manage those patients because they were our patients. And so now, I would like to just show this photograph. Like if the patient comes to you with this kind of picture, like the pelvis is discontinuous. I remember I had said that there are certain injuries which are pelviacetabular injury. Like the fracture is such that it does not disrupt the acetabulum, but it also disrupts the integrity of the pelvic ring. So suppose the patient comes to you with this kind of picture. Now, until unless we make the whole pelvis continuous, we cannot go ahead with the joint replacement. So there are two ways to do that. Either you can apply plate and make it continuous and have some kind of bony union and then go for a joint replacement, or you can use some kind of cage construct. These have come recently in the market, which goes right inside the acetabulum, fixes the ilium, pubis, and in some cases the ischium as well. And then you can apply your acetabular prosthesis on that very cage. But then since the acetabular cup is not in direct contact with the bone, these often fail in like say 5 years or 6 years. So longevity is not that good. Although it's a fascinating implant to use and the things become much easier during the operation, but eventually the patient may, the implant may fail in the near future. So our first aim is to somehow fix the fracture so that we have a bony bed and then go ahead with the conventional total joint replacement, which has stood the test of time. So just to show some of our cases which have gone into avascular necrosis, this was one case which I had fixed way back in 2020. Patient was doing quite well for around 2 years. Then he started having pain in the hip. We got an MRI done. Since we use all our implants of titanium, so we have no problems, or rather those kind of steel material which are MRI compatible. We have no issue with getting an MRI done. We got the MRI of this patient done, and we saw that the patient was going into AVN. So the patient eventually, that hip turned into arthritic, some kind of arthritis, and then we had to do a joint replacement in this patient. As you can see that we had managed the fracture quite well. The hip was congruous, patient was walking, but because of the initial insult itself, the hip was arthritic. You can see the femoral head, that you can see it's not congruous, it's not, cartilage has been lost over there. And because now people may ask, like, why not go for straight away with the joint replacement? Since we had fixed this fracture, everything was right there in place. So doing a total joint replacement in this case was like a cakewalk for us. It was just like any other total joint replacement. So you can see that everything is right there in place. It was just a conventional total hip replacement in this patient. Now this is another cases, just to show the kind of cases that come to us at trauma center. Like this patient was having blunt trauma, chest, abdomen, pelvis. He had loss of consciousness and he had ENT bleed as well. You can just imagine the kind of severe degree of severity of injury that this patient had. He had acetabular fracture of both the sides. The one on the left seems to be more severe. So that was managed first. And surprisingly, that side is still doing fine. And on the right, the patient went into paralytic ileus after the first surgery, and the second surgery could not be performed for around a month. And during that time, the head had already become arthritic. But we were already aware that this hip is not going to last. But as I said earlier, we have to make the pelvis continuous. So we fixed, despite knowing this, we fixed the fracture so that we have our next journey of doing a total hip replacement in this patient may be a bit easier. So we will fix this fracture. You can see the degree of heterotrophic ossification present over there. Heterotrophic ossification mainly happens because of the the necrosis of the muscles that happen around the hip joint because of the initial injury. So if you do not debride all the muscles properly, the hip may land up with, heterotrophic ossification. In this case, because of the heterotrophic ossification, there was a bone bridge between the ilium and the greater trochanter, and the hip could not be moved even to a, 1 or 2 degrees on either side. So this was quite a challenging case for me. And I would just show a video of this. So these were the bone pieces that I had to remove. These were the heterotrophic ossification. They were actually like bone. And then we created an acetabulum over there, fixed the acetabular cup, then the femoral stem and the femoral head, and then that completed our total hip replacement. And at 4 weeks, you can see that we have allowed the patient to sit. He is walking full weight bearing by the help of walker right now, but we are planning to mobilize this patient in future. Now, now these were the cases which we had operated, and these patients had somehow gone into avascular necrosis or the osteoarthritis. Now I will be showing you 2 cases where because of the COVID, we could not operate these patients. And these patients eventually came to us around at say 1 or 2 years. So this was one case where you can see that there is a T-type fracture of the acetabulum. And since we had to make the pelvis continuous, we fixed the anterior column first. After a few months, we fixed the posterior column. I will not go into too much surgical detail, but you can see that we have created the acetabulum, we have implanted everything. And then in the second sitting, we also plated the posterior column as well as we did a total hip replacement in the same sitting. Then the final case, again, you can see that there is too much of bone loss over there because the head has migrated inside. But surprisingly, the vascularity of the head was intact. Head was still viable, but the acetabulum was lost. So we have no option but to offer this patient a total hip replacement. So again, in this case, you can see first we went ahead with the fixation of the anterior column. We fixed the anterior column first, and then we got a CT scan before stage 2 to see the amount of bone loss. And then we did a posterior column plating, the bone grafting of the defect that was there from the head that we had taken out from the patient, and then conventional total hip replacement. As you can see, the amount of bone graft that we have prepared, you can see the particulate bone graft and some a bit larger pieces. We have to pack this inside the acetabular floor before we actually put the implants, because there has to have contact between the cup of the prosthesis and the host native bone. Then only your joint replacement can be successful. And just look at the picture on the left, the X-ray of the patient at the time of presentation, and the picture on the right, which is the final post-op X-ray. We have just operated the patient a few weeks back, so we have not got the post-operative pictures. Now, final few slides on, this is an upcoming concept like the minimally invasive percutaneous fixation. I would say that this is an exception rather than a rule, because for the acetabular fractures, you have to access the site first properly, do an anatomical reduction. Anatomical reduction cannot be done if you are not able to visualize the things properly. But there are certain scenarios where, like you say, an anterior column with posterior hemitransverse fracture. You have addressed everything from the anterior aspect, and on the posterior aspect, there is just a fracture line which is undisplaced. So you can, in those scenarios, what you can do is you can put a percutaneous screws from the anterior side itself, fixing the posterior column. So that makes avoids any further surgery from the posterior aspect as well, and the morbidity for the patient. So in those scenarios only, or if the fracture is not displaced at all, but you want to mobilize the patient early, in those scenarios, you can go for percutaneous fixation or the minimally invasive fixation. But again, I would say that this cannot be done in all the patients. Usually, it can be used in polytrauma patients where it's better to do something than not doing anything at all. And it can also be used in single, non-displaced or slightly displaced fractures. But again, I said that it's not appropriate for comminuted or highly displaced fracture, because you have to access them properly so as to get a congruous joint. Now, based on my talk, whatever cases we have done, and the evolution of acetabular surgery in general, I would say that this field has evolved drastically in the last 50 years, and more so in last 2 decades. And we have moved from the poor results of conservative management to a good and fair outcomes with open reduction and internal fixation. The anatomical reduction is a must, and that's the key. The surgery has to be meticulous, and so there is a long learning curve. The avascular necrosis of femoral head and the secondary osteoarthritis are the potential complications of injury and even after the fixation, it may happen. And neglected cases or those with poor outcomes of open reduction internal fixation will eventually require total hip replacement in future. And I would also like to take this opportunity to tell you that at Apex Trauma Center last year, we have been doing quite a good work. And last year, we did more than 1,000 surgeries, and we had a small celebration in our department over there on just 2 days back. We performed more than 1,000 major orthopedic surgeries. These are I'm talking of just the orthopedics. So we have performed more than 1,000 orthopedic surgeries of these kinds in last 1 year. And we had a small celebration. And this is, again, I would emphasize that this is a teamwork. It is not possible by a few people, handful of people. I would say it's not just the, it's also the common staff and the academic and non-academic staff, and also the other specialties, especially the anesthesia people, the trauma surgery people, and the rehabilitation team, the lab medicine. All people have, contributed to making us, the Apex Trauma Center a state-of-the-art center. And I would also like to tell you that our PDC first academic course, the post PDCC in pelvis, hip, and knee injuries, has been approved by the academic board. And thank you so very much.